and I'll be chairing this meeting. So, first of all, just a wee brief introduction. Most people across the UK had an initial 3 COVID vaccinations between late 2020 and early 2022, but haven't been offered a booster vaccine since. The group of people eligible for boosters through the NHS continues to be reduced in order to save costs. However, since April, both mRNA and Novavax COVID vaccination is available to anybody aged 12 plus, giving those who can afford to pay for them a choice, quote unquote. We will have 2 expert speakers who will talk and answer questions about how the vaccines work, what the differences between them are, and about how to discuss and respond to vaccine damage suffered by a small subset of the population without denying their lived experience. So our first speaker is Dr. Kevin Kavanagh. Kevin is board chairman of Health Watch USA, as well as being associate editor of the Journal of Patient Safety and member of the Editorial Board of Infection Control. Today, he has written over 200 op-eds regarding COVID-19 and published over 70 articles in the peer-reviewed literature, including 5 on the COVID-19 pandemic. So over to you, Dr. Kavanagh. Can't wait to hear what you've got to say.
Well, thank you very much. Let me share my screen. And thank you very much for inviting me to be here. I'm Dr. Kevin Kavanagh from Health Watch USA. And I'd like to talk to you today about vaccines and COVID-19. Now, I'm a retired clinician, so I'm going to discuss this topic from the standpoint of a clinical perspective, including clinical effects, risks, and benefits of vaccines. I'm not going to go into the intricate immunological details. So I'd first like to discuss the history of vaccines, and I think that this is important to get a historical perspective. In the United States, along with the rest of the world, vaccines have been around for a very long time. In 1775, George Washington mandated that the Continental Army undergo vaccination. George Washington had smallpox at a very young age of 19 and knew how it could be extremely severe and often fatal disease and how it could devastate his army. Smallpox at that time had a fatality rate of 30% in unvaccinated individuals. Well, the process used for vaccination at that time was called variolation. And this type of vaccination was before the cowpox vaccine, which was also used to prevent smallpox. Variolation involved taking a small amount of pus from an infected individual and placing it into a cut of the person to be vaccinated. This process and procedure had a fatality rate between 5 to 10%. So there's 2 important lessons here. First is that vaccine mandates can be necessary under certain circumstances, and they're not anti-American or anti-patriotic. And vaccines are not free of complications, but they are much better than getting the disease. Now, the premise behind vaccines is to give an experience to the body of a mild infection, which avoids the vast majority of the complications from the infection, but still imparts immunity. And oftentimes, boosters are needed. Unfortunately, herd immunity is not possible with COVID-19. One cannot obtain herd immunity with a highly mutating virus, which does not induce durable immunity. Neither vaccination nor infection provides adequate long-term immunity. So let's talk now types of vaccines. Shown here is a 1.5-year-old listing in the New York Times of just some of the vaccines used for the prevention of COVID-19. Of these, I'm going to talk about the most common ones, including the mRNA vaccines of Pfizer-BioNTech and Moderna, the protein-based vaccine of Novavax, along with the viral vector vaccine, Oxford-AstraZeneca. None of these vaccines contain a live virus. There are two mRNA vaccines that are currently being used, the Pfizer-BioNTech and the Moderna. The vaccination injects mRNA into the arm of an individual, and the mRNA then stimulates cells to make spike proteins. There are no adjuvants in the vaccine, and as listed here, the vaccine has only 7 ingredients. There's not a whole lot in there. There's not a lot of toxins. There's really not a lot of other types of chemicals that one needs to be concerned or scared about in mRNA vaccines. Now, I want you to note that the initial efficacy in preventing infections was 91%, but there was never a statement regarding duration of protection. The virus, as you know, mutated, so protection against infection is currently nowhere near this good. And it has to always be remembered that even though the vaccines are not as efficient in preventing infections, they still give substantial protection against hospitalizations and deaths. And they provide this protection for many months, but unfortunately, not for years. Now, there are two ingredients in the mRNA vaccines which are of concern. One is PEG, or polyethylene glycol, and this can rarely cause severe allergic reactions. That's one of the reasons why when you first would get the vaccine, they would ask you to stay around the facility for 15, 30 minutes to make sure you didn't have an allergic reaction. Now, many are also concerned with the spike protein, which is produced by the mRNA. However, the spike protein produced by the vaccine is much lower than that which is produced by the infection. And so I think that's what you need to remember, is that vaccines are never complication-free. They are just have less complications than getting an infection. Now, the Moderna vaccine has over 3 times the mRNA dosage as the Pfizer vaccine. Now, this is why in some countries they have not recommended Moderna for young adults, especially young adult males, because of the incidence of myocarditis. Extremely rare event. However, when there's a safer alternative in that age group, Pfizer, why not take the Pfizer vaccine? Now, conversely, in the elderly, such as what I would fall into, that age group, where your body has difficulty in mounting an immune response, the Moderna vaccine would maybe be the one you'd want to choose. Similar to the flu vaccine, when you get over the age of 65, you get a special formulation that has an increase in dosage. All right, let's talk about Novavax, which is a protein-based vaccine. So if you're still concerned about mRNA, get a Novavax vaccine, which is protein-based. It does not use PEG, but it does use an adjuvant. Novavax uses the same methodology which has been around for 30 years, and that is used with the hepatitis B vaccines. And there is some evidence that Novavax has less side effects than the mRNA vaccines. Now, the last booster I received was Novavax, simply because I felt that giving my body a more wide range of exposure to different types of antigens would be beneficial. And I can tell you, I had a headache for 2 days. I had, I think, more immediate mild reactions than what I had with some of the mRNA vaccines. But nevertheless, Novavax is a good alternative. And I think on my next booster, will try to get Novavax again. Again, just personal preference. You can mix and match these vaccines, but there's really not any good data that I've seen on the types of mixtures or mixing and matching which would be optimal. Now, the Oxford AstraZeneca vaccine is an inactivated viral vector vaccine, which has been given in 2.5 billion doses, and it's estimated to have saved 6 million lives. Let's see, I've got a... But it does have side effects, such as rare fatal blood clots. The Johnson & Johnson vaccine was also an inactivated viral vaccine, and that was available in the United States, and it was also withdrawn because of the incidence of blood clots. Now, the J&J vaccine had a good safety profile as far as it being better to get the vaccine than the infection, but it was withdrawn from the market because there were other safer alternatives. Similarly, the AstraZeneca vaccine was withdrawn due to economic reasons, which I interpreted as people were choosing another product. It was not because of the rampant blood clots making it more dangerous than an infection. But in my opinion, again, safer alternatives are available. And so it was the correct decision to withdraw the vaccine. Now, this is a graph of the world population and this was from the New York Times. It was in March of 2023 is the last data that was entered. And as can be seen, there were suboptimal rates of being fully vaccinated. I mean, honestly, everybody should be fully vaccinated. And that wasn't the case. And since March of 2023, the virus has mutated. And even if you were vaccinated with the original virus, the virus that we currently have and the strains we currently have become resistant to that. And so this doesn't represent clinically effective immunity, and boosters are needed. Now, the population's acceptance of boosters or of an additional dose has been dismal. Far too few have been boosted in order to even put a dent in the number of new cases that we'll be seeing. In the United States, we've had dismal rates of uptake of obtaining boosters. I've been very, very disappointed in that. All right, let's talk about efficacy. Now, overall, the number of hospitalizations and deaths averted from vaccination has been substantial. Before vaccination, 18% of those hospitalized died, and 44% of those admitted to the ICU died. The USC Schaefer Institute, Center for Health Policy and Economics, noted that the COVID-19 vaccine saved 2.4 million lives worldwide. And according to the CDC, individuals who were vaccinated with the September 2022 updated booster were 14 times less likely to die compared to unvaccinated individuals, and 3 times less likely to die compared to those who received the original booster. So again, that underlines why you need to, or underscores why you need to keep up with updated boosters, because your original booster or a booster from previous variants won't give you as good a protection. Now, current data regarding COVID-19 deaths between those who are vaccinated and not vaccinated is complicated. It appeared to some that those who received the vaccine had less total deaths than those, or excuse me, that those who went unvaccinated had less total deaths than those who received the vaccine. So here's a chart that if you look at total deaths, you can see that if you're vaccinated or boosted, you had more total deaths than the unvaccinated. However, this is a false statistic. It's spread widely in social media, but it's false because most people currently are vaccinated. And so looking at the data another way, you could state that 40% of the deaths occur in unvaccinated people who comprise only 20% of the population. And 39% of the deaths occurred in boosted individuals who comprised 55% of the population. So 40% of the deaths in 20% of the population, 39% of the deaths in 55% of the population. So again, vaccinations help to avert severe outcomes. Now, the latest booster is the monovalent XBB 0.1.5. This has an overall efficacy rate of 58% in preventing infections from 7 to 59 days, and a 49% efficacy rate in preventing symptomatic disease 60 to 119 days. But one of the problems that we have is durability. It's not like the measles vaccine, where you have one course of the vaccine or the vaccination, and then you're good for almost your entire life. Durability is a significant problem. So that if you look at, for example, durability and effectiveness, since the introduction of the XBB booster, that's the latest booster that was introduced this spring, the virus has mutated twice. Now, the efficacy data did contain a number of the JN.1 cases, but this virus is more resistant to the booster than the XBB strain, which the booster was targeted towards. And we're also having new strains emerging called the flirt variants. And so efficacy is going to be less. And thus, the frequent mutations making the emerging COVID-19 viral strains a moving target and very hard for vaccine production to keep up with. And for me, this is, as an aside, just one of the best reasons why we need to do other interventions, such as masking, such as improving air ventilation, so we can slow down spread and allow our vaccine process to catch up with the mutation rate. And we're not doing that. And society is I think, going to pay for it. Now, back in July of 2021, many thought the virus had been conquered. However, HealthWatch USA, which is our organization, downloaded data from the Ministry of Health of Israel, which when translated showed significant waning of protection over a 5-month period. This graft is of ages 15 to 59 years old who were vaccinated with a 2-dose mRNA Pfizer vaccine by January 2021. Now, this was when the vaccine was first made available, so all of these people have been vaccinated approximately the same time. And as you can see, the horizontal axis shows weeks, and that after 5 months, vaccine effectiveness significantly decreased for protection from deaths, which is shown on the bottom in gray, and hospitalizations, which is shown on the top in red. Now, the waning was much more pronounced for those over the age of 60, where protection of 5 to 6 months appeared to all but disappear. Overall, the data concluded the following. Most of the infections in Israel at this time were from the Delta variant. And the data concluded that in those patients who had a breakthrough infection, 8.6% were hospitalized and 2% died. And of course, if you're elderly, your chances of a favorable outcome are even less. So for those who are not vaccinated, you need to become vaccinated. And as exemplified by this data, if you're over the age of 60, you need to be boosted. And that is extremely important. You need to be boosted if you're fully vaccinated 5 months or greater prior to the availability of the booster. Or if a new variant came about and you've got a new booster, again, being boosted should be strongly considered. Now, HealthWatch USA published our Israeli data that we translated in Infection Control Today in 2 articles in late July and early August, and we received hundreds of thousands of views. I believe one article over 300,000 views. And afterwards, the CDC recommended a booster for the Delta variant in the fall of 2021. And I think that our organization played an extremely big part, an extremely large role in this because of both of the visibility of the data and that we really, I think, changed the narrative from, one shot and done from a vaccination to you've got to be boosted. And I think that that's extremely important. Now let's talk about another concern that people have is imprinting. Now, immune imprinting describes how the first exposure to a virus shapes immunological responses of subsequent exposures of anagenically similar strains. Translated, this means that your best response will be to the virus that you're first exposed to. And this is regardless of whether or not you're infected or whether or not you're vaccinated. So you can get some imprinting from infection, you can get some from vaccination. It's really not a reason to be vaccinated or not. It's just a process that occurs. Now, this slide was shown at the FDA's Vaccine and Related Biological Products Advisory Committee meeting for the approval of the bivalent booster. This slide is of a mouse study where all mice were given the original Wuhan vaccine, so the original Wuhan variant, and then they were given a wide variety of different types of boosters to see what the antigenic response would be. Now, I want you to look at the light kind of peach-colored bar graph here, and this is the monovalent 4-5 booster. This is an example of imprinting. The committee made the bivalent booster available, and I personally think that was an error. It is better than getting a booster from the wild type with the current variants, but the monovalent booster gave overall the best response. And as you can see, to the wild type virus or variant, which is shown here, which is the original Wuhan variant, this response is actually bigger than the one from the bivalent booster and equal to that to those mice that were given the monovalent booster of the original virus. So that's imprinting. You give a new virus or a new strain, but yet your response to the original variant is the same or equal. But you can also see how the monovalent gives you very good responses and greater responses to the new variants that were arising. And so this is something I think that people are concerned about, but it's a reason why I feel that you should always go with a monovalent rather than bivalent boosters. And you need to also realize that imprinting does have an advantage, that it gives you an immediate fast response to that virus. So that instead of starting all over from the get-go with nothing, you've got some memory, you've got a fast response that comes in, and then to these variants, as you can see here, your immunological response can then be more rapidly fine-tuned, and you get a better response to these new variants that you would if you were given just exposure to the other booster, to the monovalent Wuhan booster. So is that, did I explain that sort of well? I don't know. That's probably the most complicated thing we have, with the exception of my risk slides, which is coming up. Yeah, when people say it's not rocket science, this stuff is. It's extremely hard to understand, which is one of the reasons why it's so easy to distort and scare people on social media. All right, let's talk about risks. And there are risks to the vaccine. This is my longest slide. And again, I'll try to make this understandable. This is a large multinational study which was published recently in the Journal of Vaccine, which has been used by many to show how risky vaccines are, but in actuality, it demonstrates their safety. In the right-hand column, you can see that for the major vaccines, there's only a few risks which are present, and they're mainly myocarditis and pericarditis. Now, these risks are compared to the general population, regardless of whether or not they've had an infection. Risks are very dependent upon dosage given. So the data shown here is for the dosages that have the peak incidence of the complications. So, for example, some of the complications peak out on the first vaccine dose, others the second, others the third, etc., which kind of makes sense. You know, if you're going to have a severe reaction to something and you're allergic to it, you know, that usually occurs at the first exposure. Granted, after many exposures, you may develop that, but the highest incidence is going to be the first exposure. So commonly, many of these types of complications occur after the first, second, or third dosage. Now, for the Pfizer vaccine, there is an odds ratio of 2.86 for myocarditis with the second vaccine dose compared to the general population. Now, this means, and to put it in easy terms to understand, that there's a 2.86 times greater chance of developing this disorder. So for the Moderna vaccine, there's an odds ratio of 3.78 for disseminated encephalomyelitis after the first dose. This is a relatively rare entity to begin with. Of significance is the odds ratio of 6.1 for myocarditis after the second dose. This is Moderna vaccine. Young males would be expected to even have a higher incidence of myocarditis. And in this group, the incidence of myocarditis may be higher than infection. That's why some countries have said young males, etc., get a Pfizer. However, it is very possible that because you're also getting a higher dose, that you're going to have a lower incidence of complications from infection. So it may actually be off-weighed. We don't know that. Again, and we probably never will, because you'd have to have very complicated trials on a virus that keeps mutating and is a moving target. That makes what we do, a lot of it empirical rather than based upon randomized controlled studies studied over the years. Now, I'm sorry. The Oxford AstraZeneca vaccine has complications noted for cerebral sinus thrombosis, Guillain-Barré syndrome, myocarditis, pericarditis. However, if one did not receive the vaccines, these complications would be more likely to occur with an infection. And they are outweighed by avoiding the development of severe COVID-19 and long COVID. And that's what we call about a safety profile. So you have to remember George Washington's story and metaphor. The vaccines aren't risk-free, but they're much better than getting the infection. And you have to remember that the chances of being struck by lightning in your lifetime is one chance in 15,300. So when we start talking about these numbers, you need to put them in relationship to other real-life events. And vaccine complications that are severe are much less than this. Now, the American Heart Association pointed out that compared to infections, there was not an increased incidence of myocarditis after the first dose. But as we've stated, the highest incidence of myocarditis is after the second dose of the Moderna vaccine. There have been other investigations into myocarditis and vaccination, and they've observed that the following. First, let me get to the slide. They've observed the following. First, the highest risk is in 18 to 25-year-olds after the second vaccine dose. And second, the Moderna vaccine has a higher risk of myocarditis than the Pfizer vaccine. But overall, this is a rare and oftentimes mild event, especially when compared to other common complications of COVID-19, such as long COVID. And again, remember the chance of being struck by lightning, one chance in 15,300. Now, one of the more concerning symptoms and problems is that of POTS, or postural orthostatic tachycardia syndrome. Translated, it means that when you stand up, your heart goes berserk and races, and you can develop dizziness and fatigue. However, it is 5 times more common to occur with infections than with vaccinations. So let's talk about benefits. Now, vaccinations can help prevent hospitalizations, deaths, long COVID. Long COVID can occur in 20 to 30% of COVID-19 cases, and 6.9% of the entire United States adult population. This is the entire population, not those infected with COVID, but the whole adult population, 6.9% complain of symptoms of long COVID. And there's almost a 1% chance of delayed death between 30 days to 6 months after an acute COVID-19 infection. Now, these are sobering numbers, and they're of a much greater concern on a societal level than the complications from vaccines. Now, one of the best ways of preventing long COVID is with vaccination. It's imperative that one stays up to date with vaccines and boosters. So a recent meta-analysis found that 3 doses of a vaccine had a 69% efficacy against long COVID. Lundberg, Morris, and colleagues reported a dose relationship in the prevention of long COVID with a 21% reduction with 1 vaccine dose, 59% reduction with 2 doses, and a 73% reduction of long COVID with 3 doses. Now, again, the data presented is on efficacy. Durability of protection is often absent. And even if your level of protection is 75%, that still gives a 25% chance of developing long COVID. And with reinfections, vaccines alone will not provide adequate protection. Now, these are the references. These are the references which I used for the previous slide and the meta-analysis uses. And those are there for you to look up, and you can get those from the PDF download of the presentation. Now, these are the results of the CDC Pulse Survey. 6.9% of the United States adult population is complaining of symptoms of long COVID. And as you can see from the data, the younger age groups appear to be more susceptible to this disease than the older age group, 70 and above. So I guess the summary would be, if you're older, you're more likely to die. If you're younger, you're more likely to be disabled. And that's really not a good outlook of the disease, which is still circulating in our population. Now, the Pulse Survey has also been corroborated by a number of sources. This is Eurostat, which is the statistical office of the European Union, and they report that overall 15% of Europeans are reporting memory and concentration issues. And this is the insurance company If. They report that 32% of young adults in Sweden, ages 10 to 24 years of age, experience brain fog. Looking at all ages, that's a total of 14% of insured adults experience brain fog in Sweden. I like to use the statistic and actually some of the Swedish data, because that's held by many in the, of the COVID deniers of how great things could be if you do nothing, when in actuality, Sweden has major problems. And in fact, Sweden actually did quite a bit. If you look at their public health interventions, they didn't do everything, but they had much greater compliance of their population as far as restriction of travel, working from home, social distancing. All of that was recommended by Sweden and had good buy-in with their population. Now, young adults, especially highly trained athletes who are females, have developed POTS, postural orthostatic syndrome, from the infection. Your chances developing POTS from those who develop COVID-19 is 2 to 15%. So this is actually more of a concerning problem, common problem, than the myocarditis, which tends to be rarer and usually mild. Now, at 12 months post-COVID-19, 7% of children complained of symptomatic brain fog. 2.4% of children had persistent documented cognitive problems at 3, 6, and 12 months post-infection. It was stable, 2.4%. Now, brain fog is the subjective complaint from the patient. When they say cognitive impairment, that is the results of medical evaluation and testing. So this is very, very disturbing. This is just one of the concerns that you have with children that are developing SARS-CoV-2 and reinfections, and one of the reasons why I would advocate having your children vaccinated. Very important. Plus, the children spread the virus like wildfire. Don't believe this stuff where they don't spread it. In Sweden, it was a December of 2020 public health report, which is the last one. They stopped reporting the data. 70% of their non-medical outbreaks in Sweden were associated with schools that were open. And, you know, they had closed, actually, I believe they're high schools and colleges. So these were their younger children, 70%. So they spread this virus. They spread it to caregivers, spread it to teachers. And they also develop impairment from the virus, or can develop impairment. So I'm an advocate also of vaccinating children. Now, people are also becoming reinfected with COVID-19, and this has been described as playing Russian roulette, and I think, very concerning regarding persistent damage and having significant symptoms. Without mitigation, one professor has estimated that the average person may develop 7 infections by 2028. And this is, I think, significant. Again, this is without mitigation. So we need to be vigilant. We need to mitigate the disease. And as shown in this slide by Dr. Al-Ali using data, this is a slide of Dr. Al-Ali's data, which was published, I believe, in Nature. And this is of non-hospitalized patients between 30 to 90 days. This is a graph. Let me start over. As shown in this slide by Dr. Al-Ali, he used data of non-hospitalized Veterans Health Administration patients who developed COVID-19. And you can see that there is a cumulative increased risk of increased risks of complications with each subsequent reinfection. So again, this is very concerning. So when you hear about, well, you know, people aren't being hospitalized, people aren't dying, you know, that may not be actually the case as you keep getting reinfected. There are other severe outcomes besides hospitalization, although hospitalization is a big one. That's not the only severe outcome we have to worry about. Now, overall, there's a 1% excess death rate in non-hospitalized patients between 30 to 90 days post-COVID-19. And there was almost a 2% excess death rate with the reinfection, almost a 2% excess death rate with reinfection when it occurs as compared to those who did not have a secondary infection. And so that there appears to be more delayed deaths with SARS-CoV-2 infections that are more delayed deaths with SARS-CoV-2 infections than there are with acute deaths from the acute infection period. So delayed deaths are a huge problem. And new research has shown that individuals who develop COVID-19 are at an increased risk for delayed death. If not hospitalized, this risk persists for a year. If hospitalized, up to 3 years. So overall, if you are not hospitalized, the risk for delayed death is 1.62% above those who hadn't been infected with COVID-19. That they will die of a delayed effect of the virus. And this is not counting deaths from the acute infection. If hospitalized, it could be argued that there's a 7.4% of those individuals, 7.4% of those individuals will die a death that wouldn't have occurred if they didn't have an acute infection. So this is a tremendous amount of increased morbidity and mortality, which is being added on to the acute infection. And of course, these deaths can occur from a variety of other system or organ system damage. It's not just from COVID-19. See, I got ahead of myself. I'm sorry. Let me.
So
go right here. Now, this is a graphic form of the death from, or the death rates that are delayed from COVID-19. And as can be seen here in this graph, if the patient's not hospitalized, which is shown in blue, most of the delayed deaths after 30 days occurred early on. But if you are hospitalized, they can occur up to 3 years, possibly longer. We only have 3 years of data. Now, immunity from infections, I think, like almost any infection, is going to be greater than from the vaccine. Remember, the idea of the vaccine is you give an exposure of a mild infection and then you slowly build up the immunity. But this argument really doesn't matter. Neither is durable. It wanes, which is why you need to be boosted. The idea of getting an infection every single year, getting reinfected to prevent an infection, doesn't make any sense. I mean, it's ludicrous. And so even though getting boosted isn't a good option that a lot of people want to do, getting a shot that often of once a year or twice a year, in my opinion, is much preferable. It's still a better option than getting the reinfections. So we need to have better vaccines. We need to have better antivirals. Mucosal vaccines, I think, are going to be key. That's where the virus is actually given into the nose or the viral proteins, and you produce an immunological response, which started in the nasal cavity, and this produces IgA, which may help to cut down on the spread of the disease and help to impart immunity to you from getting a severe disease in the future. However, until that occurs, you need to be wearing N95 masks, which are respirators. Cloth masks do not help much with the respiratory virus. Those in themselves are not 100% because it can still enter through your eyes. You've got to be careful. So I also take a CO2 monitor to monitor ventilation. CO2 is a surrogate for clean air and good ventilation. Outdoors, it should be 425 to 450 parts per million. Indoors, I like it less than 700. If it's more than 1,000, I view that as a high-risk indoor environment and would not want to be in there very long at all. So at this point, I will conclude my talk. I'm sorry that I ran a little bit of a long time, and we'll entertain any questions that you may have. Thank you.
Our next wonderful speaker is Harriet Carroll. Harriet is a long COVID scientific consultant with a particular interest in long COVID-like vaccine reactions, something she has personal experience of. She is a spokesperson for Scottish Healthcare Workers Coalition in a campaign for clean air in hospitals and holds honorary status at Lund University and University of Aberdeen. Over to you, Harriet. Thank you.
Thank you. I've called this talk Dealing with Vaccine Injuries. Before we start, these are my disclosures, and I just want to emphasize that this talk is about vaccine injuries, so I won't be discussing benefits. That's obviously going to come across quite biased because it is. And I just want to emphasize that most people have had a vaccine and not had any known severe consequences from it. So I'm going to start with an unrelated story. A few years ago, I had a car accident. I was wearing a seatbelt and my passenger wasn't. I got a whiplash injury and eventually needed surgery, and my passenger was absolutely fine. Now, does that mean that seatbelts are net harmful? That not wearing a seatbelt is net safer? That my injury is irrelevant or acceptable? That I shouldn't talk about my injury in case it discourages seatbelt use? Would it be appropriate to tell me that seatbelts save many lives? That I must have had a previous car crash without a seatbelt? Oh, sorry. That, of course, some people get injured, that it serves me right for being a sheep and even wearing a seatbelt. To stop spreading misinformation, clearly I'm anti-seatbelt, that I should definitely drive again even if I'm worried about another injury. And would it be appropriate for doctors or researchers to tell me my injury cannot be from a seatbelt because overall they reduce car crash injuries? To run studies comparing stationary use of seatbelts to car crashes to claim that seatbelts are net safe? To tell everyone to wear seatbelts, even though they've not been tested, even people they've not been tested on, like children who need special seatbelts. and to not research mechanisms of seatbelt injury to improve their safety. If any of that seems a bit untoward, that is basically akin to the lived experience of the vaccine injured. So I'm going to talk about what we should do, and I'm going to talk about it from 3 points. I'm going to focus on the medical and scientific, and I'm going to touch very briefly on the social and political side of things. So medically, if you're a doctor and a patient presents to you with some strange symptoms after a vaccine, first of all, believe them, and second of all, do not dismiss the possibility of a vaccine cause. This is bad for the patient because it gaslights their lived experience, it doesn't tend to happen for other triggers, and it can affect legal or VDPS claims. It's also bad for society because it delays safety tracking data, which precludes informed consent to future vaccinees, and it makes medical care much harder to access because we don't know the type of injuries we're meant to be looking for. And it's bad for science because the literal aim of science is to understand the unknown, and we do this by challenging the current knowns. In our experience, this instant dismissal and denial also increases vaccine hesitancy and distrust in the medical and scientific establishment. So report to the appropriate post-marketing surveillance scheme, even if you're not sure if it's truly a vaccine injury. Test the patient with a view to diagnose. This is good for the patient and good for safety tracking. Treat them if you can. It's probably an inflammatory response, so if you can treat off-label to calm that down, we think that might be helpful, because currently a lot of doctors wait and see, and we think that might be a harmful approach that has led to some of the more chronic sequelae that we've seen. And monitor the patient in case the disease progresses or they get medication side effects. If you can, write up a case study, because case studies provide hypotheses for scientists to test. And this brings us to the 3 types of vaccine injuries. We have the known, the unknown, and the hidden. In terms of known COVID vaccine injuries, we have things like myo and pericarditis, Guillain-Barré syndrome, VITT, CVST, and of course the acute flu-like symptoms. Now, these are generally better recognized, but they can sometimes be reported in a misleading way. For example, we quite often hear about how myocarditis is mild and transient, how the risk is in men, and the classic textbook clinical presentation. And that gives the impression that clinicians know what to do, they know what to look for, and the impact will be minimal. But the reality is that the people I know with the most severe myocarditis are women. They presented so atypically, it's taken over a year to get diagnosed, and they are so disabled they've lost their jobs and are largely housebound. So you can see the reporting has been quite misleading, and that might have led to a diagnostic bias which contributed to some complications. Second, we have the unknown. And just to reiterate, all side effects at some point are unknown. So just because we don't recognize them right now doesn't mean they're not real. And this instinct to dismiss misses a key opportunity for discovery and making even safer vaccines. But scientists and public health bodies are onto this, right? Well, yes, but unfortunately, we've run into some problems. For example, several have ignored or declined our request to discuss the evidence. For example, Public Health Scotland, Dame June Rain, the Patient Safety Commissioner, and over 100 scientists we contacted. Secondly, there are limitations in how causality is often inferred, with sometimes unduly high standards. And there are 2 ways to look at causality. One is at a population level, and if we say that there is a vaccine risk, we usually base it on population risks. And these tell us at a population level, in those who have been vaccinated, is the risk of X disease higher than what we would expect in an unvaccinated population? The second is individual risks, and these are a bit harder to pass out, but they essentially tell us, is it possible for this side effect to occur? Now, these are fundamentally different questions and they require different scientific methods to understand. But one thing they both ideally need is mechanisms, and mechanisms are not always measured or even considered. Now, if we look at the World Health Organization causality assessment for adverse events, they'll say that it's basically impossible to infer N of 1 causality. Now, I don't think that's intuitively right or even scientifically correct. They have a list of criteria that would help us determine N of 1 causality. And if we look a little bit deeper into this, some of it doesn't quite make sense. For example, if you have a pre-existing autoimmune disease and it gets significantly worse soon after a vaccine, they would deem it not causally related to the vaccine. They also say if you're incubating but not presenting with an infection, then that's not causally related to the vaccine. And this one in particularly confuses me because we now have ample evidence that COVID vaccination can reactivate latent viruses. So I'm not sure what the WHO make of that. If we look at their causality algorithm, we'll see we've got here, is there a known causal association to the vaccine? And that in itself is a problematic question, because what if it's not been looked at, as in the case of myalgic encephalomyelitis? What if it's a new vaccine, so we just don't know? And where in any of this is the incentive or the instruction to investigate clinically to see if we can find a mechanism? If you want to read some critiques of the World Health Organization's assessment, you can read these papers. Now, none of this is inherently wrong, but it does seem unduly strict. And just to give an example, if I go by this algorithm, then my reaction to omeprazole has nothing to do with omeprazole. It's not causally related, and omeprazole is just a stomach drug. The third category is the hidden, and this is the most concerning category. The hidden vaccine injuries often include things like POTS, ME, MCAS, small fiber neuropathy, chronic pain syndromes, non-COVID-like reactions, and many others. And this leads to the third problem that we've come across, is there's a deep history of denial with regard to vaccine harms. And these are typically women-dominated, under-researched, medically neglected illnesses. Now, to give an example from the COVID trials, Augusto and Brianne were both part of the trials and experienced severe adverse reactions. And this paper talks about how they were treated in the trials. But one of the points they make is that phase 3 studies are not powered to detect many side effects. And as an example, they didn't pick up on VITT or myopericarditis, which raises questions about how we're assessing safety prior to rollout. In both of their cases, they're now suing their respective pharmaceutical companies. In Brianne's case, she was part of the AstraZeneca trial. She took her first vaccine, had a severe adverse reaction, and then AstraZeneca said that she can't have the next vaccine in the series, so she was counted as a non-completer in the study, and allegedly her data didn't get included in any of the outputs, including to the safety regulator. So how do you feel if you got a vaccine injury that trial participants got but were deemed by some standard according to the pharmaceutical company to be unrelated to the vaccine? And like I said, we've got a history of this. The EMA have investigated a suspected link between HPV vaccination and a chronic pain syndrome or POTS and concluded no association. But they've been critiqued by some authors on the grounds of data quality, the use of active placebos, omitted evidence, potential conflicts of interest in the investigation board, and the confusion between population and individual risk. So what evidence have we got? And I'm going to talk about long COVID-like vaccine injuries from COVID vaccines. If we think about long COVID, it's suspected or confirmed SARS-CoV-2 infection with symptoms unexplained by other things, and our response is to understand mechanisms. When we have long COVID-like vaccine injuries, we have confirmed vaccination, so none of the ambiguity of long COVID. We have symptoms unexplained by other things, and the response is largely denial. So we have a lot of similarities to long COVID, but long COVID is generally accepted, and long COVID-like vaccine injuries are generally not. I'm going to give a brief overview. This isn't an extensive overview of evidence, but it's just some examples of the current evidence we do have. In terms of autoimmunity, we have some theory and mechanisms. We've got some case studies, and there are some population studies which actually don't show very much, which suggests the risk is mostly at an individual level. In terms of endocrine dysfunction, we've got theory and mechanisms, and we've got some case studies. In terms of POTS, we've got some case studies, and we're starting to now get some population signals. In terms of clotting, we've got theory and mechanisms, and we've got some case studies. And in terms of the broad cluster of long COVID-like syndrome, we've got clinical experience, some theory and mechanisms. We've got some case studies, case series, and characterization studies. We've also got this subgroup of long COVID patients who get worse after their COVID vaccine, and we've got a potential mechanism to explain that. So we've got theoretical ideas on mechanisms, we've got case reports, we've got evidence of plausible pathology, we've got clinical experience, and we've got a growing population-based evidence. Now, no one officially are tracking or clustering symptoms to find a long COVID-like phenotype at a population level. And if they were, it would be very difficult to see a signal on a background of long COVID from SARS-CoV-2 infection. So I'm hoping that's given a bit of an overview of the complexities of causal inference in this space. What I think we need to do scientifically and medically to improve the situation is go back to the precautionary principle. We shouldn't be assuming safety until it's too late. We should have a priori thresholds for safety profiles. For example, whenever a new risk comes out, we always hear the line, but the benefits still outweigh the risks. And I'm not sure at what point, at what threshold do we stop saying that? There shouldn't be blanket recommendations for everyone to get vaccinated, particularly in populations that haven't been tested. Instead, we need to be creating a safer society for everyone. We need fair comparisons in research. We need proper saline controls, and we shouldn't be comparing vaccination risk to infection risk, because if vaccination was more dangerous than infection, we'd have a serious problem on our hand. We also need better post-marketing surveillance, including investigating pathology, understanding risk factors, and trials should store pre- and post-vaccine samples so that we can investigate mechanisms of injury if they do occur. We need better medical education and culture, and I would support specialist vaccine medical research centres for suspected adverse events. In terms of socially, what I think we can do is show more compassion. Every single one of us is one strange moment away from a life-changing event. We should avoid saying how safe the vaccines are, and if you're not sure if how you're responding is appropriate, switch vaccine for another pharmaceutical product. For example, if I said, I always get a headache when I take ibuprofen, and you said, most people respond fine to ibuprofen, that would be deemed a very unusual way to respond. We should also stop making assumptions, and I think one way to do this is we should bin the term anti-vax. There might well be a suitable place for it, but what often happens is instead of critically evaluating the information we're being given, we just say that's anti-vax and dismiss it uncritically. We should also avoid comparing to infection or hypotheticals, for example, saying, well, it would have been worse if you had COVID, because we didn't have COVID, we had a vaccine. It's a moot point. And we should support better science and medicine, because at the end of the day, how would you feel if you got an injury that patient groups knew about, but science didn't care to investigate? So you didn't give informed consent. In general, we need to talk about vaccine injuries empathetically and dispassionately, just like everything else. Finally, politically, we need to support vaccine injured patients. And one thing in the UK we should do is reform the VDPS, the Vaccine Damage Payment Scheme. We need to have a lower disability threshold, because after all, a vaccine should cause 0% disability. We should have suitable payment for the loss of life or loss of quality of life. We need a broader definition of causality, not just based on the Green Book, and we need proper clinical assessment. We need employers to take responsibility if they mandated a vaccine, for example, long-term sick pay, and we need psychological support. In terms of the media, we need to remove censorship, particularly in support groups. Journalists and hospital staff need to be able to speak openly about vaccine injuries without being accused of being anti-vax and dismissed. And hopefully I've kind of already covered what we can do in research and healthcare. But overall, I think the social, political, scientific, and medical are all linked. And if we are kinder in one area, I think the other areas will follow. If you have been affected by a vaccine injury, I would strongly recommend you get in touch with a support group. And I want to end the talk by saying that if you generally support vaccines, the thing I want you to take away from this talk is that talking about vaccine injuries is the most pro-vaccine thing we can do, because after all, it's not very pro-vaccine to not want safer vaccines. On that note, I'd like to thank you very much for listening, and I look forward to some questions.
Well, thank you very, very much indeed, Harriet.